Sorry, we are running late. And thank you so much, Dr. Meenakshi, for having me here. I'm going to try and make my talk a little short so that Dr. Meenakshi can take the rest of the time. Basically, I'm talking about glaucoma in eyes with uveitis, and we all know that risk of glaucoma in such eyes is a little higher compared to eyes without inflammation. And also, as ma'am mentioned, Dr. Radhikan, right in the beginning of a session, that we do need to understand that if the optic neuropathy hasn't set in, you're basically having uveitis related ocular hypertension, which can sometimes be entities only associated with viral or steroid response in such eyes. But even otherwise, still the optic neuropathy doesn't set in, it's basically secondary ocular hypertension. And uveitic glaucomas are basically about 10 to 20% of secondary glaucomas. And most common uveitic conditions which cause glaucoma are sarcoidosis, viral uveitis, juvenile idiopathic arthritis-induced uveitis, Fuchs, and of course, use of steroids is a very, very high risk for glaucoma in such eyes again. I'm going to just quickly skip some of it because we don't have the time. Another thing to remember in uveitic glaucoma and other secondary glaucomas, that their course can be different from primary glaucomas. They can progress faster and they can land up having the need of surgical intervention much faster than primary glaucomas. So one has to be a little more careful. The other small message I'd like to give is sometimes you can have a burnt out disease, which means that if you had transient increase in pressure in such eyes, which led to some amount of optic neuropathy, but with optimal treatment of the inflammation, if the things have become under control and the pressures have come down automatically, you might not need to treat these patients because of the optic neuropathy that's there. That's a rare thing, but something to remember. A quick slide to tell you that what are the possible reasons for your glaucoma to develop in such eyes. One is, of course, the trabecular meshwork itself can get clogged because of the debris, the inflammatory cells, and the aqueous humor itself can have more protein in it. Second, more often causes trabeculitis, where the trabecular meshwork is getting inflamed, classically seen in hypertensive uveitis associated with viral etiologies. Acute angle closure. It's something that we all see in our clinic when the pupil is getting occluded with membranes or posterior synechiae. You can have iris bombay and secondary angle closure. Or there's sometimes other changes, non-pupillary block mechanisms like rotation of the ciliary body or choroidal effusion that can also cause an angle closure. Chronic angle closure, where the anterior synechiae are being formed in the periphery without pupillary block, is also not uncommon, especially in chronically long drawn uveitic cases. Steroid-induced glaucoma, as I said, is something, again, 40% of such eyes can develop steroid-induced glaucoma, and especially patients who had pre-existing risk of open angle disease or family history or extreme ages. Very young patients and the older ones are at a higher risk. Sometimes in chronic stages, where if you have panuveitis and ischemia, even neovascular glaucoma can be seen. I'm going to quickly go through all this and skip it and just talk about the clinical classification. So one is, of course, hypertensive uveitis, where you have inflammatory ocular hypertension syndromes. I think this is sometimes misdiagnosed and not treated appropriately. That's why I wanted to just highlight this entity, and I'll show you one or two examples. Acute uveitic angle closure. That is another mechanism which we just mentioned, either pupillary block or a mixed mechanism where you're developing anterior synechiae as well, and steroid induced, not just the drops, but intravitreal injections. It's not uncommon for us to see that. Here, this is a classical picture where you have very subtle inflammation, no posterior synechiae, classical of hypertensive uveitis associated with viral illnesses. This is a pupillary block due to posterior synechiae, broad anterior synechiae in eyes with, let's say, granulomatous uveitis, and you can see over here a long-standing, a steroid releasing implant in the vitreous. So it's important to take a good history, symptoms, look at a good examination, but of course doing gonioscopy is extremely important in such eyes, along with the applanation tonometry. The optic nerve has to be evaluated, as we mentioned in the earlier part of the IC, that sometimes it's difficult to do imaging in these eyes because of the clarity or your posterior synechiae. So you have to rely more on what can be appreciated over the functional tests. The imaging of the anterior chamber angle can sometimes also give you extra information, especially if the ciliary body is getting rotated or something. Those things can be picked up on UBM. So here again, the common causes of hypertensive uveitis are viral herpes, induced uveitis, CMV, rubella, and sometimes even sarcoidosis. So important thing to remember is that they come with an acute onset of blurred vision where you can have signs of inflammation and very high pressures, as like you can see over here. 45-year-old healthy male, unilateral condition where there's epithelial edema, few medium-sized KPs. They are very unusual looking. Sometimes you can have coin-shaped KPs as well. Little bit of flare, no posterior signic, and high pressures. And you will find open angles when you do a gonioscopy. And even the ONH will look healthy in the initial stages. And these patients respond beautifully to steroids. And sometimes the anti-glaucoma medication also can be reduced very quickly, but they can relapse. And once you know what you're dealing with, you can do either an AC tap to confirm the viral etiology, or sometimes the clinical picture is typical. Giving them antivirals topically and oral can help you not only treat it but reduce the chances of relapse. So CMV is another common entity where you can have hypertensive anterior uveitis, again seen more in males than females, mostly unilateral, and typical KPs which are coin-shaped and fine stellate KPs can also be seen. Again, topical steroids are very helpful, and anti-glaucomas can be something that can change the course of this disease. Herpes zoster, again, very typical picture where you will have iris atrophy, sectoral or large, and these patients can again respond well with anti-glaucoma, but they might even require a surgical intervention if they're not responding. Fuchs heterochromic uveitis can again have an incidence of glaucoma. The important message in Fuchs is that when you see only mild inflammation in such eyes, you don't need to give them steroids to treat that. There's enough indication there's enough evidence published in the literature that these eyes do not require steroids if the inflammation is very mild. And they also do very well to cataract surgery if they have developed cataract, and if they have glaucoma, which is almost about 20 to 50% chance, then they need treatment with medical management or surgical intervention. And classical moth-eaten appearance of the iris can also help you clinch the diagnosis. So I already mentioned about the treatment of Fuchs. In acute uveitic angle closure, a PI can be required. If you have pupillary block, you might need to do more than one PI, and sometimes if the inflammation is active, they can even block. So you need to give aggressive steroid treatment in the post-laser period. And if you're dealing with an area where the cynical closure has happened, these patients often require surgical intervention. And here you'll see that the glaucoma can follow long-term even if uveitis is under control. A classical picture of pupillary block where you'll need a PI, and very often these PIs can block. So large PIs, more than one, and aggressively treat them with steroids and cycloplegics. So you can see over here 2 large PIs made and the pupillary block is settled. Chronic mixed mechanism again, where you can have multiple things happening, pupillary block, non-pupillary block mechanism as well, maybe some steroid response also thrown in, and also maybe some trabecular scarring or inflammation in it. So again, you have to have a multi-pronged approach in treating such eyes. Granulomatous eyes can have a higher tendency of developing uncontrolled glaucoma, which might later require a surgery as well. Again, over here, you have the options of doing trabs and tubes in such eyes, and there's a lot of evidence available, that they both do well. Sometimes you choose tubes right in the beginning, especially in eyes where the active inflammation is there when you need to do a surgery, or patients who have extreme ages like too young or too old, or patients who have coexisting glaucoma as well. So steroid-induced, I think we already discussed, even in the cornea and glaucoma related conditions. So you have to be wise in choosing the steroid also depending upon the inflammation, and monitor such eyes. Some of them can also return back to normal pressures after cessation of steroids, and some of them can continue to have prolonged increased IOP requiring further management. So general principles are, of course, control the inflammation and control the IOP as well. For the inflammation, not just steroids, but sometimes treating the etiology is important, whether it's viral or let's say a tubercular uveitis. And immunomodulators can also be helpful. So really having a rheumatologist on board in situations where it's required can be helpful. In glaucoma management, it's the anti-glaucoma medication that you start with, and only PG analogs are something that you need to be careful about. Rho kinase inhibitors have been given, but pilocarpine definitely should be avoided. Surgical, I already mentioned. Trabs also do well, but you have a risk of hypotony and risk of failure in trabeculectomy because of this conjunctival scarring very often, and also cataracts can progress and CME can develop. The GDDs, basically the valves, do well. Valvular or non-valvular devices do well, but they again have a higher risk of failure in these eyes as well. So you have to be careful either way. Cyclophotocoagulation can be your last resort. So just showing the results. and I think I discussed this. So just to conclude, the uveitic glaucoma is a complex form of secondary glaucoma with a high risk of visual morbidity, and it is challenging to treat, but you have to use a multidisciplinary approach to treat such eyes and identify the risk factors and regularly monitor these guys to further to achieve the success and save the eyes from the long-term visual loss. Thank you.
Thank you so much, Dr. Reena. Very beautifully covered the topic. I now request Dr.